I welcome Tilman and Moritz from Mainz in Germany in the radiology department. And the topic is using a technology that I have to say, and as a disclosure, that I'm very interested in. It's using oxygenation, blood oxygenation as a contrast donor. And while I'm doing a lot of work for looking at microvascular function or vascular function in the coronary and also in the cerebrovascular territories, there have been some scattered papers in the past of using that for looking at the actual blood oxygenation in patients with shunt lesions and with congenital heart disease. And it has not been that widely used now yet, but this paper may change some of the views of some people on that. So without further ado, and this is a featured paper, so we will have time, a little bit more time than usual. We will not discuss two, but just one paper this time. I'm really looking forward, and thanks again, Tilman and Moritz, for joining. The paper has been recently published, and it's called Cardiac MRI-based right to left ventricular blood pool T2 relaxation times ratio correlates with exercise capacity in patients with chronic heart failure. And I think this topic is especially important because it's about heart failure, because we need to get better at identifying those patients that have heart failure, because sometimes just looking at ejection fraction doesn't tell us a lot. So I consider this paper extremely important and timely. So I would ask you to share your screen and then walk us through the paper.
Yes. First of all, thank you, Matthias, for inviting us. We're really humbled and excited to be here and show the work that Moritz and me did over the last couple of years, especially with regard to the heart failure. So I will be here a little bit more the elder statesman, turning 40 yesterday. So kind of this is my post-birthday present here to talk about T2 mapping and what we do with this to look not only at the myocardium, but at the blood. And I will start sharing my screen. I hope that you see it right now. I just want to basically in the beginning show you what was the initial idea a couple of years ago, exactly 2019, I think, before we switched into the actual paper. But this is actually the original idea that I had in the night shift while I was looking at cardiac MRI stuff that I did over the day. And I saw the patient on the left and I saw the patient on the right, both with kind of diseased right hearts, as everybody can obviously see. But I was wondering why the hell is looking the blood pool so different in between those two scans. And of course, I mean, we all know that it can't be that it's just a simple thing of blood flow or anything else. So I basically came across the thing that is also known for decades, that the T2 relaxation time is kind of related to the oxygenation. And we just thought about investing it in a kind of very simple way, use routinely acquired T2 mapping sequences and compare the ratio in between the left and the right ventricle to judge the oxygenation. And what you see in this first idea that we published basically a year ago in JMRI was to look at shunt patients and use it as kind of a shunt detecting possibility. Very simple. So here, this is an ARVC patient, and you see kind of an obvious ratio that the right ventricle is less oxygenated than the left one. In the middle, a healthy volunteer was kind of the same trend. And here on this side, basically, we see kind of a similar signal suggesting that the oxygenation in the right ventricle is close to the one in the left ventricle. And it turns out this patient has a relevant shunt. Okay, so we published this and we were happy because we know about shunts. But actually, shunts are quite rare in our hospital. But what we really actually look at is a lot of heart failure patients. And now we just thought about, hey, why not extend the sign to the actual other side of the spectrum? So move away from the hyper-oxygen or more oxygenated blood in shunts to the heart failure patients, where we could see potentially a reduction in the oxygen content in the right ventricle compared to healthy volunteers. And actually, this was the birthplace of the idea that actually then Moritz and me executed then in this study. And now I pass on the ball to the actual leading person for this, Moritz, and he will walk you through the paper step by step.
Well, thank you very much for that kind introduction. We are going to just start right out. Let me scroll down here a little bit. So I don't think I have to talk much about the background. We all know that heart failure is not only a very prevalent disease, but also one that affects the patients that have it quite a lot, and outcomes are bad for, if we look at 5-year mortalities. So there is obviously a need to study it further, as we've already heard. And one way that it is studied is by outcomes, obviously, and because outcomes are sometimes hard to judge or hard to study, they use surrogates, and one of those surrogates is the 6-minute walking test. That's just a basic walking exercise where heart failure patients actually walk for 6 minutes up and down a corridor, and we basically record in the end how far they've walked. And that has been validated pretty well and has shown to correlate with prognosis, and is therefore also been put into international heart failure guidelines, because it's basically a surrogate for their functional capacity. And we know for heart failure patients that functional capacity probably reaches maximum far more early than it reaches for us. For example, just by walking down a corridor, they're maxed out on their functional capacity. So we obviously know CMR has a recommendation for heart failure workup as well. And so the thought was basically, why not combine those two? And as Tilman has explained before, that all came with the background of this T2 blood pool technique. And that's basically what we did, because all these patients are from our heart failure unit, so they get referred for CMR and get a comprehensive protocol, including T2 mapping, and they also get a comprehensive assessment for clinical from the clinical side, including the 6-minute walking test. So the hypothesis really was that, as we've seen with the shunt patients, that ratio moves towards equilibrium between left and right ventricle, that in heart failure patients, that ratio drops. So the blood saturation, the oxygen blood saturation in the right ventricle will be lower than in healthy patients. And that would be due to the hypothesis that the peripheral blood desaturation is higher in these patients because they need more oxygen from the blood. So the blood that comes back to the right ventricle obviously then has a lower oxygen saturation. So to prove that, we set up a retrospective study at our center. We screened roughly 300 patients, and if we move along to the flow chart here, you can see the majority of those patients, the big chunk, actually had to be excluded because they were not heart failure patients in the end, but they had different disease that was actually the cause of their symptoms, or they were bedridden and therefore couldn't participate in the 6-minute walking tests. So that left us with roughly 130 patients that actually had a CMR and a 6-minute walking test. But then, as for the clinical reasons, also CMR reasons sometimes prevented that, which then resulted in a final study cohort of exactly 70 patients that were included in this retrospective study. So these were all patients that had a complete CMR, including T2 mapping. They had a complete 6-minute walking test, and they had their labs. So they had BNP values drawn at the time of the 6-minute walking test and at the CMR. So these are pretty well characterized, and we are pretty confident in this cohort. So what we did then for our CMR protocol is a basic protocol that can be employed for a variety of cardiomyopathies or heart failure workup. And I think we want to concentrate on the T2 mapping side here, And it's just it's a commercially available sequence with 3 preparation pulses and a 3-beat recovery period. So it's no specifically tailored sequence for the blood pool actually, but it's the one that we also use for the myocardium, which makes it quite different from previous attempts that aimed at actually quantifying the blood oxygenation in the blood. Those were mostly specifically tailored sequences with longer or more preparation pulses. Okay, so let's move on. After the 6-minute walking test, those results were all taken, and then what you usually do with those results is you calculate percentiles, because obviously age and sex is a confounding factor in that analysis. So there's established formulas by different researchers, and that's what was done here as well. So this is really the core piece of the study, and this is basically the same picture that you saw earlier from that Tilman showed you, but really we've moved to the right of the spectrum here. And if I switch back here real quick, you can see this is where the ratio is sort of the same. This is the healthy person, and this is the right heart disease that has also still a difference between left and right. And now we are shifting that frame to the right by 1, basically. So you can see here 3 T2 maps of a healthy person here on the left, then a person with heart failure in the middle, and a person with severe heart failure on the right. And what you can see right from the get-go is that this ratio will be different than this ratio, right? And obviously that also still holds true if you look at the T2 relaxation times here and that we've gathered from the regions of interest in both the ventricles. And also that explains how that was measured. We took pretty basic 4-chamber view T2 maps and put ROIs in the right and left blood pool, and that's it. So there's no really big post-processing going on or anything. The only thing that you have to be careful about is to avoid flow artifacts. And we did evaluate whether it was necessary to put more regions of interest in there or evaluate the short axis as well. But really there was quite concordant results. So we decided to use the 4-chamber view just for the ease of use, because you can teach anyone to do that, and it's visually it's the easiest to gather, I think. So then you can ask what's the difference between the middle patient and the patient on the right, and if we see a difference here, is that something that translates into 6-minute walking tests or functional capacity of that patient actually? And luckily we were able to show exactly that. And let me scroll down here. So this is the typical assessment of heart failure. You do the reduced ejection fraction, mild reduced, and the preserved ejection fraction. This is what we usually see when we only look at ejection fraction, obviously. And of course, when you look at ejection fraction, you will see exactly the corresponding ranges that you would assume are there. But also, I want to focus you on the etiologies of the heart failure. So as you can see here, it's quite a diverse bunch of patients that we have in our cohort. So there are heterogeneities in here that we don't want to neglect. But still, I think when we go further down, we can see that the RV-LVT2 ratio is reduced in comparison to the healthy volunteers, which have about like a 0.7 ratio. And regardless of preserved ejection fraction, mildly reduced, or reduced ejection fraction, we see a drop in the ratio. But as you remember, we not only saw a drop that was constant for all patients, but we also saw a different subgroup of patients. So these patients were actually patients that were also reached less distance in the 6-minute walking test. And that's where it actually gets interesting, because sometimes these patients will stop their 6-minute walking test due to dyspnea, and then obviously they won't reach as long as distance. And that is something that we try to predict by our RV/LV T2 ratio. So this is just the exercise physiology of the patients, basically, and the correlation of our results with that. So there's patients with dyspnea and patients without dyspnea, and as you can see, there's some significant differences which are highlighted here in bold. That is the scar burden, which was quantified LGE basically, then the RV/LV T2 ratio, and then obviously the distance, because patients with dyspnea are not going to walk as far as patients without dyspnea. That is something that you'd assume from the get-go. And if you look at all these parameters, which we can quantify, including T1 mapping of the myocardium actually and ECV, you can see there's not a significant difference for this cohort, at least between those two patient groups, right? And you don't see the prediction from the CMR for dyspnea or no dyspnea, and therefore for the distance. So this is something we've already talked about. We did reproducibility analysis for the 4-chamber and short axis views. That was quite good, so we chose the 4-chamber view. And then now this is what we think is the core, basically core message. We can correlate the ratio with percentiles of nominal distance, and there are significant differences between patients with dyspnea, without dyspnea, and healthy controls actually. So basically, we're able to predict. We're able to predict exercise capacity from the resting state supine CMR, which is quite interesting because usually for functional assessment you'd need stuff like treadmill exercises, which then require you to set up a whole new exercise test imaging department, basically, because that is something that requires preparation and more post-processing capabilities as well. So this is something that we've already said. We can, the RV/LV T2 ratio predicts exercise capacity in these patients. So then we have to think about sort of why is that, and that is something that I've already touched on in the beginning. It's basically the hypothesis that the oxygen affinity or the curve has to shift to the left if we want to improve oxygen uptake, or shift to the right if we want to improve delivery to target tissues. So because we can't shift to the left very easily, it has to shift to the right for heart failure patients. So they take more oxygen in the periphery, and therefore at the end of the systemic circulation we'll have a higher desaturation of the blood. And that is basically what we see, and that is why it's darker, or obviously the ratio is lower. So it's important to note that this is not directly quantifying oxygen saturation. It is just this phenomenon is just a hint on oxygen saturation, and it's based on that, but we're not able to quantify that. That is also because there's no invasive reference for the blood oxygenations in this study. And finally, of course, there's some limitations to this study. It's a cross-sectional design, so there's no causal relationship really between the ratio and the distance walked. And also, we will have to see prognostic implications in further studies because there's no longitudinal data. And then we did all the CMRs were performed at 3 Tesla, and it would probably it is needed that we have more field strength as well. But the initial study that Tilman touched on in the beginning, that was performed actually on both 1.5 and 3 Tesla. So there is an indication that it works on both field strengths, but obviously that needs further validation. So, and then with that, I think I'll hand over to Tilman, who will touch a bit on the outlook of what we're doing in the future and what we think is the next steps that need to be taken.
Yeah.
Keep in mind, we have only 9 minutes left, so keep it short so that we have time for discussion.
Sure. I think the beauty of this whole stuff is that it's really fast and easy, right? So it uses a routine sequence, which is nothing fancy. Technically would work on every scanner that has T2 mapping applications, and the post-processing takes less than 10 seconds to do. We did a lot of reproducibility testing for this stuff, so we are pretty confident that it will also work on other things. However, this is, as Moritz said, a first glimpse into these heart failure things, and we have to learn how it would react, for example, in exercise testing directly, how it would work when we look at maybe invasive correlation. Is there something more to gain? And prognostic data, I think, is key in a large cohort of patients, and that is actually what we plan to do. And just a quick look, so other groups are picking this up and also look at pre and post treatment trends. So this is a paper from the Gießen group looking at chronic thromboembolic pulmonary hypertension pre-treatment and post-treatment, and they can also show this kind of trend for pulmonary hypertension. So maybe it's not only the heart failure that is interesting, but also like pulmonary hypertension on the other side of the heart that could be very interesting to look at. And with this, we are really excited to discuss this with you. And once again, thank you for the opportunity to present our work.
Well, thank you very much, Moritz, for the great presentation, and Tilman for your assessment. So, of course, if a new technology shows up or a new application of a known technology, the first question always has to be, okay, about reproducibility. You have already addressed that to some extent. And then accuracy and confounders that may play a role here. So you already said that it's not directly, we do not know to what extent it reflects oxygenation, and T2 is even less specific for oxygen than T2 star. So do you have any concerns about confounders such as hemoglobin, hematocrit, and stuff? Have you looked at that?
So actually, we are doing that at the moment together with our friends in Rome, who actually run an interventional CMR business and have actually catheters for blood oxygenation in the right and the left heart. And we are performing at the moment a study where we try to correlate for that. It's also getting more and more complicated. If you look, for example, at patients that have coexisting pulmonary disease, for example, that may confound these results. We did not stratify for that yet, but we need more data and more outlook to really know if this very simple sign is really accurate. And of course, we are very eager to try it out against more sophisticated methods of measuring blood oxygenation. I mean, the Ohio State group has wonderful applications. However, they take roughly 8 minutes to actually do that, right? So it's a big difference, and I guess they will be more accurate and more close to the actual oxygenation in the ventricle. But on the other side, if a simple tool that works everywhere can kind of give you a glimpse into the exercise capacity of heart failure patients, then I would also accept a little bit of uncertainty.
Okay, there's a question from Ruud van Heeswijk. The used T2 preps were originally chosen for measuring myocardial T2s in the order of 30 to 60 milliseconds, but you measure T2s up to 150. So with some uncertainty at that level, so do you expect to increase your sensitivity if you would sensitize the sequence to higher T2 values?
Yeah. That's something that, which is basically what Tilman just said. I mean, that's what the Ohio group did, right? And which is they tailored their sequence to the blood pool actually. And of course, if you have longer prep, then your confidence will probably increase for the blood pool measurements.
Yes, and I totally agree. This is not an optimal sequence that is actually tailored to measure the blood pool. It's focused on the myocardium, right? That is the intentional sense of that. But We kind of looked at the very simplistic one-size-fits-all system in the beginning, it seems to work relatively good if you compare it to the kind of uncertainty that you're having. But totally agree, a sequence that would be more tailored to these realization times would definitely be an improvement, right? Yeah.
And then there were questions about the use of long axis versus short axis. So you briefly mentioned that it appears easier. You said that probably anybody can do a four-chamber view. I mean, a correct four-chamber view is maybe not that trivial, but I agree that this is something at least everybody can see whether this is a four-chamber view or not. But were there other reasons why you chose four-chamber instead of a short axis, which many people are just more used to?
Actually, we also run the analysis post hoc on the short axis, and the results are super similar. So it doesn't change that much. The first paper we published with short axis imaging, we did all the validation on short axis and long axis, and in the end, it doesn't matter. Do whatever you prefer. Also, a strict axial plane to the left and the right ventricle that shows both the cavities would also work, right? So you just need kind of a good look at both without prominent inflow artifacts or big artifacts, all that. So the discussion about which axis to use, I would tend more to be the short axis guy because I'm always looking at short axis mapping. Moritz found it easier to look at the long axis things, and for the numbers, it doesn't matter. Yeah.
I'm also more long axis guy because I think it's an advantage to see the valves and to see the context, including the atria. So regarding flow-induced artifacts, were you concerned about that? Because transplanar flow could it be, of course, a problem in the close to the LVOT, but more probably for short axis. So was this a concern for you at all?
Absolutely, yes. And that is something that you have to be careful for, not to place your ROI directly in those flow artifacts, because that will mess up your measurements. And that is something which I always advocated for during the study, that use the four-chamber view, because you can more easily identify those artifacts and avoid them than, for example, in a basal short axis slice where you might not be aware that it's actually an artifact.
Yeah. And then there's a question from Fahime Ganbari. Did you observe any distinctive patterns differentiating HFpEF with and without known postcapillary or exercise-induced pulmonary hypertension? So I guess the question is, have you looked at other patient groups aside from congenital heart disease and heart failure?
Yeah, so actually we're doing that at the moment. It's too early actually to spin out a message of that. We are excited about that. Let's phrase it like this. And we believe there could be some value in this. But we can't show you kind of enough evidence at the moment. And in addition, I think what is really needed for us is a very good or very well characterized HFpEF cohort, right? So we have a small cohort with like really extensive invasive validation data, and we try to look at that and learn from it and be smarter. But it's still some time. We need some time to answer that question, definitely.
Yeah. And before we have to wrap up, unless there are any other urgent questions, then please speak up or put the question into the chat. Oh yeah, Nicole, go ahead.
I do have a quick question. So, can you comment on mapping T2 in the blood pool, where every time the heart beats, you're going to get a refresh of magnetization, and so you don't have necessarily the same magnetization heartbeat to heartbeat. How does your T2 mapping sequence function in the presence of that exchanging or flow of blood in and refreshed blood every single heartbeat?
I wish I would know the answer, actually. I don't know how much the influence of that is. Yeah, I guess you are absolutely right. That should create some problems, but I can't give you an exact number for the actual output of that. Yeah.
Thanks. That's a totally good answer.
Just be honest, right?
And last question from Gustavo Lima de Cruz. So are there any other parameter maps that you're interested in the future, T2 star, QSM?
So T2 star is one of them. Also, we are a little bit looking into these combined T1 and T2 based approaches that have been published by other groups, right? And we would also like to learn and see if the combination of T1 and T2 basically would help us get further along to also correct for the hematocrit via T1 based imaging. And yeah, this is something what I would think first is also, I think there are three things that we really want to do is, first of all, we want to understand how accurate our sequence is in compared to real life data, to invasive measurements, to show us the truth. Most likely we'll see that it's not perfect, but maybe good enough. And then number 2 and 3 would be, let's optimize the sequence in a way that it works as accurate as possible and but delivers the message. And my hope in the end is, of course, on a technical base, it's not perfect, but if we also can show that it's a prognostic parameter that outperforms all resting supine functional measurements that we did, and we did basically everything that CMR could do for a standard protocol, then it would be, again, a benefit for the patients to know that.
Thank you so much. I think this was is really an important paper. And as you said, it is there's more work to be done for sure. But on the other hand, I think it is extremely promising. And sometimes, and I agree with you here, or you didn't explicitly say it, but I think sometimes the imperfect things, when they're simple enough and give just the right amount of added information that we need in a clinical context, is still extremely valuable. And we sometimes make the mistake, from my point of view, especially in the MR business, we try to go for perfection. We spend years on coming up with new stuff and try to make it even better and forget that it is already at a useful level. So I think we always have to strive for perfection, but we sometimes have to accept that in a clinical context, information like that you get within a few seconds in a regular MR can be extremely useful. So that's why I'm grateful for your research and wish you all the best for that. And thanks again for coming and presenting that. The next journal club would have been presented by Nicole, but Nicole gets into a well-deserved vacation. So it will be me on August 2nd presenting something. I'm still waiting for, or I have notified them just recently, but it will be, as much as I can say, is that it will be about stress, CMR stress perfusion, so first pass perfusion. And there's some very interesting new data out there, and so we'll discuss that next time. And then Nicole will take over then the one thereafter.